Yeah, so CT and MRI, meaning the patients are generally acutely so ill that there is hardly any time for CT MRIs. And it's cumbersome, of course. But yes, we have done in a couple of patients CT MRIs too. So echocardiographic assessment gives you the details of the sinus involved, the chamber where the aneurysm exits, size at the aortic end and exit point, associated lesions, which might mean that you do not want to do, meaning transcatheter closure and send them primarily for surgery. But of course, certain associated lesions we can address. And of course, the RV, LV size and function and their progress over time. But the most important measurement is the aortic end. And we believe that just like the surgeon does it, we believe in closing it at the aortic end and not at the exit points. Because if we close it at the exit points and leave behind some aneurysm, it's a potentially you convert a ruptured sinus of Valsalva aneurysm into an unruptured one with a potential to rupture elsewhere. So having said that, TE is superior to transthoracic echo, and we believe that intraprocedural TE is mandatory. However, some people, once they have had a TE done, they would even do it by transthoracic, especially because you can monitor for AR occurrence during the procedure, and angiography is complementary, though in really sick patients you can give away with. And why I'm saying angiography is complementary, this is what was echo, if you see. And what has happened here is that we think it's a very slam dunk kind of a procedure. But if you look at the angiography, you see that there are not one but two aneurysms, one unruptured one, all coming from a common aortic end. And therefore, we could oversize the device. Instead of an 8 by 6, we put in a 10 by 8 and managed to seal off the entire aneurysm completely. So as far as the closure technique is concerned, it's fairly simple. We require a GA is simply because patient has to be done according to us under transesophageal echo guidance. A root aortogram and eleocranial works good when the RSOV is draining into the RA, and the RAO for the RVOT outflow rupturing RSOVs. And you cross the defect from the aortic side and snare from the venous side, establish the standard AV loop, very akin to VSD, transcatheter VSD closure. Assess the size on both TE as well as angio. Arvind, where is he? Balloon sizing we feel is not necessary at all. Okay. Delivery sheath you bring in from the femoral vein to the aorta, deploy the device under TE guidance, as well as you might want to do angiography before final release. Ensure that there is no increase in AR and really try and see whether the AR etiology-wise is due to encroachment of the device or is it an afterload mismatch. And coronary compression, though described in literature, according to us is a non-issue because the sinus and especially the enlarged sinus is way too low for the device to come on the coronaries. You monitor for AV blocks, however, during the procedure, and here it is. Now, when the device is, when your the RSOV is exiting into the RA, don't simply with the flow take the thermoangle wire up into the pulmonary artery, necessarily use that to your advantage and either get into the SVC or the IVC. Snaring becomes very simple and the procedure becomes short. Somehow this laptop, I can't see myself. What's happening? Okay, so there it is. So sizing the defect, as I mentioned, 2 to 4 millimeter larger aortic end device. But for really large RSOVs, even we go up to 6 millimeters larger. Define the anatomy with it, guide device, and more importantly, the TE can be so good, as I'll show you in the next few images, that you need not even do any, just like for ASD closures, we need not even do contrast angiography. So having said that, here it is the typical RCS to RA fistula, which you can see, you can measure the aortic end and the exit end, and here you can see the sheath traversing it, the device, the aortic disc out, device finally deployed. Before release, you want to do what you call the echo again on color, watch in all views that there is no AR. So here is it after release. So, but this is another RSOV that I'm trying to show. Can you actually figure out if there is any AR? But we want to go frame by frame and report any AR that has occurred because AR is responsible for the, meaning increasing AR, or if you cause new AR, that can be responsible for the long-term outcomes being not too good. So after having published our initial experience of 20 cases, that's when we were really learning with the rest of the world how to do these RSOV closures, and the success rates therein was 90%. Mind you, this was with the previous generation of Amplatzer devices, in the sense that the Amplatzer, the original Amplatzer device, where the largest device is 16 by 14, and the failures, the only two failures was, one was 11 millimeter at the aortic end, and despite using the 16 by 14 repeatedly, we kept on slipping, despite being 5 millimeters oversized, and we failed there, sent for surgery. The other one, there was a significant AR occurrence, whatever angle we came by, and we cannot unfortunately predict beforehand, or maybe we were on a learning curve there, and therefore we did not do it. Therein we got a follow-up, midterm follow-up up to 5 years of all our patients, and we found that the besides the improvement in the dramatic improvement in the symptomatology, the shunts disappeared, tended to disappear. AR, there was no progression of AR. Importantly, there was no recurrence of the RSOVs, or there was no infective endocarditis or device embolization. So the exclusion criteria, then we made it out as being basis for the Amplatzer duct occluder. If the aortic end were more than 12 millimeter, we wouldn't do them. We wouldn't do them if there were multiple rupture sites. However, both these today are not necessarily exclusion criteria, and we have done these. I'll show you those. Associated defects, again, we've done some patients with associated defects also. But yes, if there is significant AR with a VSD, then you want to send this patient for surgery. And of course, you need to rule out infective endocarditis. So the device is used, of course, Amplatzer duct occluder, you can maximum go till 10 millimeter size, less than 11, you do not want to do an Amplatzer duct occluder. But in recent times, due to availability of the LifeTech device, we addressed larger ones. And given the peculiar shape of the RSOV, it is the duct occluder which is most suited for these devices, for this RSOV closure. So here, now this was one such in 2014, because of the aortic end being 12 millimeters and an associated AR, we said no to doing this. But this same thing, very similar patient in 2024, we were able to fix it. In fact, this was fixed in Ankur's lab with the 18 by 16 ADO. So here it is. Now this is a patient who had a 14-year history. You rarely get such RSOVs. For 14 years, he knew he had an RSOV, but not highly symptomatic, did not undergo a closure, but later on, of course, with chamber enlargements, presented in atrial fibrillation, and that's when one realized that he has a small VSD and AR, was in AFib and was in florid failure. And we decided it was the RSOV rupture that had, meaning the enlargement of that and AFib that had caused it. We went ahead and closed it and accepted that AR that was there pre-existing and the VSD as well. This is 6 months follow-up, patient in sinus rhythm on MO, and a 5-year follow-up subsequently. You see that the AR hasn't really progressed. The LV size has come down, though the VSD and AR persists. This was a 54-year-old gentleman. So then here is one which is really a price case. This was supposed to be going for publication, and that's how this is images in cardiology wise. The first picture is a massively enlarged heart, and the last picture is the at discharge heart size. This was during the COVID-19. Patient ran from pillar to post, bad organ dysfunction, both multi-organ dysfunction, and we could manage to fix this with a LifeTech. This was aortic end 17 millimeters. Unfortunately, the movies are not playing, but here you can see 22 by 20 LifeTech Sierra. That was importantly without any contrast at all. So success rates 90%, and all our initial 5 failures were related to, now the 50 plus cases were related to the large defect size in 4, and I'll show you the failures, and those were during the ADO days. Since LifeTech times, if you have attempted something, we almost always manage to do it. Here you can see why at the aortic end, this 16 by 14 largest ADO slipped in, and it's gone and sat at the exit end, and that's not where you're supposed to close the defect. and needless to say, by evening the hemolysis had increased and the device looked ghastly, wanting to get embolized types, and we sent for surgery. Then the other one, yeah, this is one. This is the one.
But
the other one was, yeah.
no, Prafulla, I wanted to ask you in that question, that previous patient, why did you not make the use of that other exit and close this at the level
No,
of...
there is just one exit here.
Okay.
There is and what has happened is that the device was meant to be at the aortic end, the 16 by 14, that was the largest available. And you have brought it there and it slips. Okay, it slips, but it's closed here. And there was a residual shunt, so we accepted it. But what I'm trying to tell you that the exit point is very flimsy edges wise. If at all the aortic end is
here,
stouter.
in this angiogram, you can see one more exit point. Do
No,
you
there
agree
is
with me
none.
or no?
It's just that.
Play this.
Said that. Now here, we should not have ever attempted it. This is one of our failures. Patient was virtually multi-organ failure, a goner kind of a thing. And here there were kind of two defects. Okay. And we crossed twice. We managed both. And we already released the smaller defect at the exit point we have closed. And then the larger one we were not able to do. So we used what I would never ever use in an arterial level shunt, an ASD device for recipe, and you can see by the size of it is such an oversized device, it's got no business. But our joy was short-lived. Okay, in fact the urine output started coming and we were all celebrating. But before getting out of the cath lab, this is what we noticed and sent this patient to the surgeons. Surgeon was very much on standby. Unfortunately, this patient never made it. The ASD device is into the RV outflow. So here it is. Associated interventions, I'm telling you, which are amenable to transcatheter treatment should be done. Transcatheter ASD closure in 2, which we reported in 1. Coarctation stenting. Again, one of my patients underwent an RF ablation for a PJRT. The EP guy came over and took multiple veins and did the PJRT, and then we went on to close the RSOV. This was during the India Live, an ASD plus what you call, not India Live, TCT India, ASD and an RSOV done together at the same time. So like there are recent times, these are my last couple of slides, amongst the usual things, residual shunts disappearing, even the ARs also not increasing, and we believe that the ARs don't necessarily occur related to the encroachment on the leaflets, but could occur because of what you call afterload mismatch. And then we've had 2 complete heart blocks, both of them, meaning one coming 24 hours later, oversizing, of course, a penchant for oversizing maybe, that is one thing. But both of them responded, and then there is this other entity, a transient LV dysfunction, that for which our moderator for the day, Dr. Girish Sabnis, recently described, meaning this transient LV dysfunction occurrence at all aortic level shunts, whether it be PDA, AP window or a RSOV. So transient LV dysfunction, which is also due to the afterload mismatch possibly, and which disappears. So here is the complete heart block fellow who was discharged on steroids, responded to steroids, and this is 4 years later, he is still in sinus rhythm. So in conclusion, it is a safe and effective alternative to surgery in properly selected cases of RSOV. Amplatzer duct occluder or the duplicate non-amplatzer duct occluders are the best suited. I wouldn't for one use the other kinds of devices for RSOVs. And having said that, oversizing, sometimes you go up to 6 millimeters larger for especially the larger defects. And the immediate and intermediate term results are encouraging. Of course, we need longer follow-ups. Thank you.
Many operators are apprehensive of entrapping the RCA. So would you comment on that? Is it possible?
Yeah, that's what I was trying to say, that all these RSOVs are necessarily out of the sinus deformity, correct? And the sinus eventually comes down so low. So there is just no problem about when you come with an aortic disc that you will encroach on the right coronary ostium at all. I think it's a non-issue. But having said that, in the literature review, I've come across where they have had an acute MI occurring because of right coronary encroachment. That's what. Not one but two case reports.
And could you give some tips on avoiding railroading through the tricuspid chordae?
Oh yeah, that's why I'm trying to tell you that if you are getting into the RA, if the exit point is RA, never ever accept to go up into the pulmonary artery. Now when you, of course, the RVOT once you go to the pulmonary artery, the way to do it is that best way is to take a right corner, means you are going to go and snare it from the pulmonary artery. So your entry into this thing, either you might use a pigtail and go all the way, like what Bharat does it for transcatheter pulmonary valves, or you use a balloon tipped catheter and go into the pulmonary artery. Then and only then do you take your snare up into the pulmonary artery. Because again, I've seen amateurs, who are trying to do the AV railroad, entrapping some of the chordae also, and you get that ghastly, looking thing. And we have those I think we should make films out of that also, that what entrapment of the chordae is. And you should never ever accept that and come out. You will end up getting acute TR on table here.
Any thoughts on retrograde closure?
Yes, there is one case report again on retrograde business done by Manjunath's group, Jaydeva group, and they have reported it also, that retrograde route is easy and can be done types. Again, you can't obviously do it with an ADO. You will then only be stenting the defect because the aortic disc is on the wrong side by doing retrograde. So the ideal device would be something like an ADO2. Okay, it's got a lot of what you call Bharat.
Why not muscular VSD?
Yes. Now muscular VSDs, again, the track and the metal that you leave behind is way too much is what I feel. Again, muscular VSD has got a fixed length. That's about all. Correct? That is what it is. And you don't need necessarily. If at all you need something like an ADO device, which will, that flimsy sock, it's going to pull back and then you are able to do it. Having said that, we discussed Konar device. There are case reports of people having done with Konar device as well. And Dr. Mahajan is still there. I don't know, I thought I saw him. Yeah, his favorite device is Konar device. So he's done a RSOV with a Konar device also.
One in KM, but one or two my student that Abhay Tirke had done with the Konar device at periphery.
Yeah, so retrograde for that. But the point is that ADO2 is actually, to me, the best one. But the problem with ADO2 is that it's not available in the sizes to close an RSOV. Because that's exactly what we do for PDA long ducts, right? Any length of duct does not matter. Because the ADO2 has apparently got a good, accordion effect.
So, in fact, two large RSOVs I had done with a muscular VSD device, too large. And both patients had hemolysis for 3 days. And after 3 days, it was subsided.
Okay. No, I'm okay. Muscular VSD device is still okay.
And both the patients had a residual RVOT gradient of around 12 millimeters of mercury.
Yeah. So retrograde, we have done retrograde in one patient, which actually Amay Amonkar reported it also. He wrote it as a letter to the editor, Jack Invasive. So what was this patient? It was an acquired RSOV. Patient had aortoarthritis on the aortic root angiogram. Came with an acute MR, as also an RSOV burrowing into the IAS and rupturing into the LA. So the options were what? You had to do a transeptal puncture and create a railroad if at all. So we went in with a ADO, a reverse, ADO with the aortic disc on the wrong side. And it was possible to close the RSOV because the rupture wasn't that great. We were able to successfully do it and hoping that patient's acute problem will settle, but it never did settle because the burrowing, it was an acquired one, burrowed into the septum and into the mitral valve apparatus. That's my only experience or the need to do a retrograde. Otherwise, I don't think there is any need to do a retrograde.
Thank you, sir.
Thank you, sir.
Sir, two more questions. So one is, how do you oversize? How much do you oversize the device?
Exactly.
And secondly, can you do a coronary protection as Girish says in cases, like should you do a CT before it? Because most of the cases we have never had problems with the coronary obstruction. But if the coronary is low and we come to know on the CT, should we do a protection like we do in? Just a thought.
Yeah, it's a thought. But my thing is that in an RSOV scenario where the sinus is so enlarged, the coronaries will never come in the way. Especially the right coronary is the only issue. If at all you get it from the left coronary, it's an acquired RSOV. So coronaries is not an issue. I don't think so.
Sizing.
Sizing. Yeah, sizing wise, we'll land up sizing more very often, you know. So 4 millimeter oversizing to me is pretty much the norm in our lab. And when you have got the real large ones, especially I showed you this one that was the failed one. There it looked measurement wise just 10 millimeter, and a 16 millimeter device kept going down. So you are okay to go up till 6 millimeters more. If you have used a large device, 2 instances, that was because of the vagal effect possibly, we've had complete heart blocks in 2 instances. Both of them have recovered. So that is one thing that you got to keep in mind. And of course, why transesophageal? Because your ability to monitor an AR is the best with a transesophageal echo. I don't think limited transthoracic echocardiography you can figure out as you are doing the procedure to be able to monitor the AR.
Sir, one more thing is entry site is where you size, right? Is there an instance where you plug the exit site? Like if there is a very bad patient,
Yeah.
so or you think the exit site should not be plugged? It's only
No, I strongly believe exit site should not be plugged, number one. But automatically, if the length of the defect, the length of the tract is not too much, okay, the exit site, the PA end of the ADO sits on the exit side anyway. But you think you are in one dimension sizing for the aortic end. But we have had, I've also got pictures of those, but in account of time I did not put those, where it has actually tilted partially past the aortic end. But yet at the entry point, leaving a little bit of the aneurysm also, we have been able to close. It's like that. So I believe strongly that you should close it at the aortic end only. And that too, all aortocameral fistulas, whatever it be.
So one more comment, sir. So just another hole to plug. I think that was your article, 2008. I think it requires now more data because I think KM is doing more RSOVs. I think a newer publication is required because we need to maintain our highest numbers.
Girish is around. Girish has already told the world about LV dysfunction that occurs. By the way, LV dysfunction after RSOV closure is a case report in JACC. It's been published by up north, Rishikesh AIMS. They already published that.
It's a phenomenon of afterload mismatch.
Absolutely. So that is there.
And
By the way, that chapter is still, meaning that chapter and our new one is coming into that same
Just
textbook
wanted to
where you help.
make one comment that no coronary, no coronary, no coronary. I have had one sudden cardiac death after a successful closure. After RSOV, 24 hours later, just patient was found dead. And the postmortem was done and there was a thrombus inside the right coronary artery. This patient's postmortem was done, I think, at Sion. This is some 25 years back or maybe 20 years back. Many years
which
back.
device was it, sir?
ADO1. Absolutely uneventful procedure.
Oh,
Discharged the next morning or next evening and was found dead the morning after that at home.
on single antiplatelet.
Single antiplatelet.
Because one more thing that we never talked about the antiplatelet therapy for AP windows, for coronary cameral fistulas as well as here. For coronary cameral fistula, so we upfront start anticoagulation itself along with antiplatelet, isn't it? That's the protocol. And out here because it is closer to the aorta, it makes sense to go dual antiplatelet. That's all I would say.
This is a high pressure, there is no cul-de-sac. Why would you
do it? That's what.
No, but Prafulla, I have got 9 cases of coronary AV fistula closed by device, not coiled. I have never used any antiplatelet, anticoagulant, nothing. And my follow-up is of 4 years, no issues.
No, but
See, proximal fistulas, if you do that, it's still fine. But distal fistulas, where the entire coronary artery tree is what you call enlarged and dilated, it's a potential nidus. In fact, that fistula is taking away all that, giving you a good blood flow. You close the exit point, which means that enlarged coronaries in there is a nidus for infarction. And Bharat actually made me aware of it. His very good friend, Larry Latson, has written all about his philosophy about infarctions. And not only transcatheter closures of coronary cameral fistula, even surgical closures of coronary cameral fistulas, there are MIs occurring on the follow-up. So, in fact, it makes you wonder whether distal fistulas of coronary cameral fistula, just to abolish the murmur, if the shunt ain't great, why should you even close them? Especially when they come in the adult.